And for this part of the webinar, I wanted to go over, first of all, how emotional health problems, how common they are in children and adolescents with juvenile myositis. And then secondly, to discuss how these problems are related to having juvenile myositis. And lastly, thinking about how we can address emotional health for patients with juvenile myositis. So we know that juvenile myositis is a challenging disease to have. It involves muscle inflammation, which can cause weakness, fatigue, and pain, as well as skin rashes and calcinosis that can be visibly stigmatizing for our patients. And we know that this condition also involves intense treatments involving medication side effects, and that it is a chronic disease that continues over time with the possibility of flaring. And then while dealing with this disease, our patients and families are having to see many doctors for many visits, labs, and other tests. So thinking about emotional health, it is a critical part of overall health. And this is really stated in the Leading Health Initiatives for Healthy People 2020, released by the U.S. Department of Health and Human Services. So one of the statements from that initiative says that emotional health is essential to a person's well-being, healthy family and interpersonal relationships, and ability to live a full and productive life. And another statement from the Leading Health Initiative also really relates this to having chronic conditions and physical health conditions. And this statement says that emotional health has a serious impact on physical health and is associated with the prevalence, progression, and outcome of some of today's most pressing chronic diseases. So this is really relevant to our patients with juvenile myositis. So how common are emotional health problems for the youth who are affected? Well, there hasn't been that much research, unfortunately, but we do know some things. So thinking about more broadly quality of life, there was a survey done to identify aspects of high quality care. And this survey was conducted by the Childhood Arthritis and Rheumatology Research Alliance, Juvenile Dermatomyositis Quality Measures Work Group. And in this survey, there was a top 5 aspects of quality care that were identified. And one of them was overall quality of life. And you can see that for patients and families, this was really ranked number 1. And for healthcare professionals, although it was in the top 5, it actually ranked number 5. So a bit of a discrepancy, but still illustrating that quality of life is important for patients with juvenile myositis. Now, a big part of quality of life is the psychosocial aspect of quality of life. And we know from studies in the past that quality of life scores for juvenile dermatomyositis patients score below those of healthy children. And these include scores for emotional, behavioral, and social limitations, as well as family activities and bodily pain. More recently, in partnership with CureJM and the Childhood Arthritis and Rheumatology Research Association, or CARA, a survey was conducted of patients and parents. And this survey included responses from 58 juvenile dermatomyositis patients and 153 parents. And it was asking about how common symptoms of emotional health problems are for youth with juvenile myositis. And what we found was that 1 in 3 of the respondents for patients responded that they did have depression symptoms, and 1 in 2 responded that they had symptoms of anxiety, and 1 in 4 responded that they had difficulty coping with or adjusting to having the illness of juvenile myositis. So when we looked at the actual prevalence or percentage of patients who were reporting these symptoms, we found that the percentages matched what the slide I just showed you. So the depression was about 28%, anxiety 33%, and adjustment disorder at 19%, followed by other disorders listed there. And these ones in orange were disorders that were reported to be diagnosed by a clinician. However, we also found that an additional percentage of patients had self-reported symptoms, meaning those that had not yet been diagnosed by a clinician. And so you can see that an additional 12% said that they had undiagnosed depression symptoms, an additional 21% said that they had yet undiagnosed anxiety symptoms, and you can see as follows. So emotional health needs of juvenile myositis patients may very well be under-recognized. So how are these emotional health problems related to having juvenile myositis? Well, there are many potential factors that could affect emotional health in patients with juvenile myositis. These include limitations in the physical realm, the social realm, family, and academic. Also having to deal with pain, dealing with stigma, whether it's visible due to rashes or invisible due to just the knowledge of having a rare condition. Also, the daily burden of managing a chronic disease, such as having to take a variety of medications and having to have many clinic visits and coordinate complex care. The uncertainty of having juvenile myositis can take an emotional toll, both in the short term surrounding diagnosis and trying to understand what all of it means, but also in the long term, thinking about worries about flaring. The inflammation itself may also impact emotional health, as we have more and more research indicating a connection between inflammation and mental health disorders. And the parent and caregiver well-being can also impact a young person's well-being who has juvenile myositis. In addition, we have heritability factors or genetic factors which can also play a part. So in the survey that we did of the 58 juvenile myositis patients, we also asked about which factors they thought that were related to their disease were impacting their mental health. And what we found was that the ratings were relatively high for things like worrying about flare, this is patients in the blue, stress on their family, changes in appearance, physical limitation, and worrying about the future, and limits on outdoor activities, and feeling like they had to grow up too fast. And when we contrasted this to the parents in orange, we found that similarly parents gave high ratings as well. But we did notice some discrepancies in terms of parents maybe not identifying worrying about flare as being high up, and certainly worrying about the future also showed a bit of a discrepancy as well as some other categories. So taking a step back, we know that from other chronic disease of childhood that the impact of emotional health on longer-term outcomes can be profound, such as things like disease control and adherence, how well or how optimally the healthcare system is being used by patients and families, transitioning successfully to adult care can be affected, school performance, later work productivity, and later peer and family relationships, as well as the overall health-related quality of life. So how can we address emotional health for patients with juvenile myositis? There's three sort of main buckets that we can think about. The first is education about emotional health and awareness for patients, parents, and families. The second is adequate identification of patients and family members who are having emotional health challenges. And then once we've identified those in need, providing intervention for those who have emotional health problems. So how are we doing with addressing mental health at this stage for our juvenile myositis patients? Well, some of the work that we've done through CARA has shown that we really don't have a lot of resources within the pediatric rheumatology clinic community. So only 31% of CARA centers across North America had an affiliated social work or psychologist. And when we asked the rheumatologists more specifically if they thought symptoms of depression and anxiety were being adequately identified, only less than half thought that things were being adequately identified. but the majority, 85%, were in support of routine mental health screening. However, only 2% of those responding to the survey said that they did any routine or regular screening of mental health using tools that have been validated or proven to be accurate for detection. And furthermore, just under half thought that even after those were identified who needed further evaluation, there was not very good connection to mental health services. So this indicates that not only are there limited resources, but there is a need to have a more routine screening and regular screening and improve connection to mental health services for those who are identified. Some additional work was done asking social workers and psychologists who are affiliated with CARA sites where they thought the gaps in mental health care were. And they mainly pointed out 5 areas. The first was that both depression and anxiety really needed to be a focus, because depression and anxiety often occur together, and anxiety may be under-recognized and not paid enough attention to, and can really cause problems with function for our young people. The second was the need to also provide resources for intervention for illness-related adjustment and coping difficulty. And thirdly, related to that, the social workers and psychologists really thought that there should be more focus on helping caregivers with coping and distress related to their children having juvenile myositis. Fourth, social workers and psychologists thought that there needed to be more mental health support surrounding that transition period to adult care. And lastly, they identified a need for more peer support programs throughout the course of the disease. So thinking about what is it going to take to improve the mental health resources and interventions that we have, one way to think about it is, well, what are the barriers that need to be crossed? So rheumatologists said that they had limited time and limited staff resources, and there was poor availability of mental health providers. And the behavioral health providers, the social workers and the psychologists, thought that, once they were there and they were able to provide services, but they needed more policies and protocols, things to follow that made things more standardized for how they would deliver their services. And they also thought that the social workers could be doing more within the mental health realm, as opposed to some of the other services that they were providing. Patients and parents thought that even after they saw mental health providers, if they were able to have access to, let's say, a counselor or a psychologist, they felt that there needed to be a greater understanding by the mental health professionals of the actual uniqueness of the disease of juvenile myositis. This was in addition to long wait times for mental health providers and a discomfort with talking to a stranger. So while these things can seem discouraging, it is noted that none of these parties thought that these were insurmountable and that there are real steps that can be taken to improve mental health services. And one of the biggest things that the patients and families can do is to really advocate for these services if they're not available at your center, or figuring out what is available at your center and making sure you use the services that might be available so that the clinical staff and the people in charge of the clinics and of the hospital know that these services are valuable to our patients and families with juvenile myositis. So the take-home messages for this section of our webinar are that youth with juvenile myositis are at risk for emotional health problems, and these problems can negatively impact physical and social well-being. Education about emotional health and regular screening for emotional health problems will help us to better recognize and address emotional health challenges. Intervention for emotional health problems can help, and work is ongoing to make resources and services more accessible for patients and families. Thank you.
So the two main topics I'll discuss are some preliminary results from a focus group study that Dr. Knight, myself, and Dr. Don Wahizzi at Montefiore Children's were asked to do with support from CureJM, and then some next steps in terms of emotional health screening and referral that we were working on together with CureJM support. So, as Dr. Knight was saying, there's relatively few studies that address emotional health among young people with juvenile myositis. And at the time that we started the focus group study I'll be discussing, there had never been any qualitative studies before. So qualitative research is research that is usually based on the use of interviews, either individual interviews or group interviews. They're usually open-ended studies. So, you're basically trying to learn from the experiences of people without bringing a lot of preconceptions to the study. And they're meant to really generate hypotheses rather than proving hypotheses. So we're trying to think of or elicit new information that we might not even be aware of from folks that we're taking care of. And so the point of qualitative research is that it's really centered around the lived experience of those folks who are participating in it. So we were able to do 6 focus groups with parents of youth with juvenile myositis at the 2018 CureJM National Family Conference. And what we did was we grouped parents based on their child's age. So we had a group of parents whose kids were 6 to 12 years old, 13 to 17 years old, and then a young adult group, 18 to 21 years old. And there were 2 focus groups per age range. And each focus group is about 60 minutes long. We audio recorded them and then had them transcribed verbatim, making them anonymous though, getting rid of any identifying information. And we had folks taking notes in the room so that if there was nonverbal communication, like body language or tone of voice or things like that, it could still be kind of documented well. So we started each focus group by asking parents to list 3 words or phrases that encapsulate juvenile myositis related emotional health themes. And then after that, we had a semi-structured discussion of the themes that were raised. And we ended the groups by asking about preferences for different emotional health interventions on a 1 to 5 scale. So 1 would be an intervention that's considered very undesirable, and 5 would be an intervention that's very desirable. So this, what you see is a word cloud, which is basically where the themes that we asked people to write, like those 3 phrases or words that we wanted them to write down, we basically tallied up how often those appeared, and the size of the word on this image corresponds to how many times that word was expressed by participants in the study. And so immediately you see the themes that really pop out are concerns around anxiety and depression among youth with juvenile myositis. Somewhat encouragingly, there was also this theme of strength and resilience that was elicited, and we didn't really ask specifically about that. More on that in just a bit. So going through all of the results would sort of be beyond the scope of this brief presentation, but quickly I can walk you through a couple of the themes that we found. So broadly, the first set of themes are around the types of emotional challenges that parents identified. So the first theme around that was the impact of the diagnosis of juvenile myositis itself on emotional health, both initially at the time of diagnosis and then how that evolves over time and plays out in daily life. The second theme, which is really important, is the idea that diagnosis of juvenile myositis affects other family members, especially siblings, and that oftentimes the well-being of those siblings and other extended family members really could use more attention. And then parents themselves have incredibly important emotional health needs that require further attention, and many of the parents were very forthcoming with us about some of the challenges they have faced and had to cope with. And then that theme of resiliency that I mentioned in the word cloud slide before this one did show up prominently, particularly among the oldest age group, that young adult age group. And it seemed that many of the parents in that group identified that their child or now young adult with juvenile myositis had gone through quite a bit, and not that life is necessarily easy now, but that there was a lot of adaptation and coping that developed over time. And looking back on the experience, there was an ability to make meaningful kind of basically develop a sense of meaning and purpose around what had happened and position it within a broader life narrative. The other set of themes were really around screening and intervention. So first big one was barriers to treatment. So an example of that would be lack of access to emotional health resources. So many of the parents in these focus groups were very, very savvy, very equipped to deal with the medical system, and yet there's such a lack of pediatric mental health providers that a lot of times, even if families and their physicians and their children knew that there's a major issue that needs to be addressed, it could be really hard to find the right kind of help. Insurance also often could be a barrier because a lot of times it wouldn't cover a broad array of services or providers. And oftentimes it could be tough to find providers who are accepting new patients. The next theme is desired interventions. So parents talked about what they think would be helpful ways to address emotional health. And some of the ideas that came up were uses of technology, like smartphone apps and things like that, that might be helpful, or also the importance of peer support groups. And then the third theme here was the importance of providers or physicians in screening and intervention. So parents really identified their pediatric rheumatologists and to some extent other care providers in their children's lives as being very important. So, if we as providers normalize the idea that emotional health is part of the broader health issues that we're discussing, and we talk about how that's a universal theme in our visits, that families felt a lot more comfortable bringing up those topics and exploring them in greater depth. And then the last theme, which is really interesting, is many parents identified that their child or young adult with juvenile myositis would not always feel comfortable openly reporting that they're feeling distressed, and that oftentimes they would just say, "Oh, I'm fine," or they would kind of minimize the degree of their challenges, and that sometimes parents themselves felt like they had to kind of speak up and bring up the issue. So they talked about that as a potential barrier to helping kids and adolescents and young adults get the care they need. So in this slide, we're kind of demonstrating the results of that 1 to 5 scale about preferred screening interventions and emotional health interventions. So what we found is that basically parents felt that counseling for their child, peer support groups for their child, and counseling for other family members would be the most desirable interventions. And there was support for increased access to both print and online informational resources. There was also support for the use of medication as part of mental health treatment. And while it doesn't score as highly, when we went to the actual transcripts and explored the themes and discussion around that, a lot of the parents really talked about how it's important that medication be used in the right context. So not jumping straight to that, but if it's needed, it's needed. So next steps in this study, we're on the cusp of finishing up the analyses and starting to prepare the manuscript for publication. So we really hope to share the findings from this study with the broader medical and scientific community. And we think it would be great if future studies would evaluate youth or patient perspective in addition to the parent perspective that we elicited. And I should point out that there's a study with youth with JDM specifically that came from the group in the United Kingdom, and that was published recently in the Pediatric Rheumatology Online Journal. And some of the findings really resonate with what Dr. Knight was discussing earlier. We did really find in our study that there are major gaps in screening and referral, and it's hard to access quality care. And this is an issue not just in JM, but also in really all pediatric chronic illnesses. So the next question that we feel is very urgent is how can we start filling in these gaps? So in regards to that, in discussion with CureJM leadership and allied clinicians and researchers in the areas of pediatric rheumatology, psychiatry, psychology, and so on, we've been thinking about how to start developing and implementing routine screening and referral for emotional health issues in juvenile myositis clinics. So there are other pediatric chronic illness populations and advocacy organizations that have done fantastic work in this regard. One example would be the International Committee on Mental Health and Cystic Fibrosis. So that group has actually published really interesting recommendations for screening both patients with cystic fibrosis, but also their parents for depression and anxiety. So here is a kind of flow chart that goes through the pathway that they talk about in that cystic fibrosis guideline. So at the top of the slide, what you see is that they really say it's important to have ongoing prevention and education around the themes of emotional health. And the idea here is that even if somebody isn't expressing great distress at a given moment, every person is dealing with some degree of stress in their day-to-day life. Every person needs to constantly work on and develop their repertoire of self-care and supportive care for themselves and others. So this is a theme that should just be universal. But in addition to that kind of universal prevention and education focus, then there's screening specifically for depression and anxiety. So they recommend annual screening for depression and anxiety symptoms, or as needed if during a routine visit, the theme or the issue comes up in conversation. To do this screening, they recommend using really well-validated questionnaires, including the PHQ-9, which is a questionnaire that screens for depression, and the G87, which is used to screen for pediatric anxiety. And these surveys, basically, you answer them and they give a score. The score can be in a normal range, which suggests that overall things are pretty stable, in a mild range, suggesting that there's some mild degree of distress and maybe some supportive intervention and further education and connection to resources would be helpful. But then there are those young people who will be in that elevated range where they have moderate or even severe symptoms of depression, anxiety, and that's a much more urgent situation. So in those settings, there really needs to be at that time or very, very soon after really detailed clinical assessment to sort of go into detail about, okay, to what extent is this child or a young person impaired by their depression or anxiety symptoms? What are some of their preferences for treatment? And then safety planning, particularly in the case of those youth who might be actively experiencing suicidal ideation. Having done that assessment, then you can connect kids and families to evidence-based psychological and pharmacological treatments to really help as best as we can. And then at that point, you reassess on an ongoing basis and at least annually in a formal capacity. So you kind of loop back to the top of the flow chart. So other next steps, we're kind of working on in the Childhood Arthritis and Rheumatology Research Alliance, which is a multi-center collaborative pediatric rheumatology research organization. Dr. Knight is one of the leaders of the mental health work group, and we're working on developing consensus statements about screening and referral across really all pediatric rheumatic populations, but it should include juvenile myositis. So that's work that's ongoing. And then there's further studies in juvenile myositis and related conditions, meaning other rheumatic conditions. So as Suzanne mentioned, there was a CARA small grant that was recently awarded for us to start working on piloting screening and referral in juvenile myositis specialty clinics. There's also a CARA grant that was awarded earlier this year to study adverse childhood experiences in juvenile arthritis patients. So adverse childhood experiences are intense early life stressors. So really intense things like death of a parent or parental incarceration or different forms of deprivation or neglect and things like that. We actually know from other patient populations that there's a strong relationship between these early childhood experiences and later health status, including for people with autoimmune diseases, but it hasn't been well studied in pediatric rheumatology. So this is the first grant really awarded to do that kind of work. And then we're definitely thinking about many other types of studies and grants. For example, I've been working on some grants that would fund work on the relationship between psychological stress and mental and physical health outcomes in juvenile myositis patients. So a lot of work to do, but we're feeling really energized right now, and we feel like some of this preliminary work we're doing has demonstrated the need, and that's helping us to identify other stakeholders who can help support this kind of work. If you ever have any ideas or perspectives to share that you think would inform our research agenda and the advocacy we do, definitely feel free to pass that on to leadership in Cure JM. And we really just wanted to also thank families who participated in our focus group study and other studies. And thanks to all of you who are listening today on the webinar.
Some of our goals tonight are going to be to recognize signs and symptoms of depression and anxiety in children and adolescents. You heard a lot already about how the rates are much higher for anxiety and depression in children with juvenile myositis. And now we're going to talk about what that actually looks like in these children, and then learn some practical strategies to address these symptoms and how we manage them from a behavioral health perspective. The effect of chronic illness on mental health is well established. As a result of your illness, you may feel fatigue, pain, weakness, or experience side effects of medications. You might feel different from your peers. Your child might feel different from their peers or face other social issues related to their condition. And all of these factors affect mood. So we now appreciate the bidirectional effects between physical and mental health. That's been spoken about a lot already tonight. Depression and anxiety can affect treatment adherence, actually worsen physical disease through inflammation and lead to poor functioning and missing school. So it's really critically important to address all aspects of health for optimal well-being. Depression refers to changes in mood, thinking, and activity that cause impairment in functioning. Rates of depression and suicidality among young people have been rising over the past 10 years, and suicidality is the second leading cause of death among adolescents and young adults. As you've heard already, youth with chronic illness have higher rates of emotional health problems, and it's imperative that we begin to systematically recognize and address these issues through some of the screening measures that both Drs. Kaveh Ardalan and Knight were mentioning. Typical age of onset for depression is in adolescence. About 13% of teenagers report symptoms consistent with a major depressive episode in the past year. Younger children can also get depressed, however, it's much less common. As mentioned, physical illness increases the risk for depression, and evidence suggests that youth with rheumatological disease have higher prevalence of mood disorders compared to children with other chronic illnesses. So what does depression look like in kids and teenagers? It's not just feeling sad, it also affects cognitive and physical functioning. For youth, it's important to remember that chronic irritability can replace sad mood. So a teenager can just look chronically irritable and not necessarily look sad. Also in teenagers, it's not uncommon to appear happy and energetic at times and still be depressed. Adolescents are very good at masking their symptoms. And Dr. Ardalan had mentioned in one of the focus groups about children minimizing their symptoms and parents not necessarily being aware. Loss of interest or lack of pleasure can look like not wanting to play video games or stopping participation in cherished sports or clubs. For children with chronic illness, excessive guilt, typically feeling as if you're a burden on your family, can be a sign of depression. Depression also affects cognition, making concentration and decision-making difficult, which can affect school performance. And self-deprecating thoughts such as I'm worthless or I'm no good, those really critical, self-critical thoughts are common. Physical symptoms of depression include eating or sleeping too much or too little, having no energy, which can sometimes be a symptom of the illness, or experiencing pain and other physical symptoms like headaches, stomach aches, or nausea. So therapy is an effective treatment for mild depression, with cognitive behavioral therapy having the most evidence for effectiveness in kids and teenagers. And the combination of therapy and medications has been shown to be most helpful for moderate to severe depression. But we're going to talk more about therapy and meds later. If I asked you all to raise your hand if you've experienced anxiety at some point in life, probably everyone would raise their hand. Of course, I can't see you, but this would likely be the case because anxiety is a normal adaptive emotion. If we didn't have anxiety, we wouldn't be able to recognize and escape dangerous situations, such as avoiding stepping on a snake which is critical for me living in North Carolina, in the woods or running for a predator on the plains. Anxiety is the fight or flight or freeze response, and it is biologically programmed. So anxiety helps us do well at school and at work and provides that motivation to study for the test or prepare for a talk. Anxiety, however, becomes a problem when we think every stick is a snake and therefore we can't go for walks outside, or when we're unable to take a test because we're so nervous we might fail. When anxiety interferes with functioning and overwhelms our ability to cope, it becomes a disorder. Anxiety is the most common childhood mental health diagnosis. Whereas depression typically onsets in adolescence, anxiety is a disorder of childhood and usually starts around the ages of 6 to 12, with a lifetime prevalence of 30%. As I mentioned, children with chronic physical conditions have a higher prevalence of anxiety, and untreated anxiety disorders in childhood are a risk factor for depression and substance use in adolescence. There are also many different types of anxiety disorders, such as panic disorder, separation anxiety, and social anxiety, which we don't have time to get into today, but I'm happy to answer questions. So as I mentioned, anxiety is the fight, flight, or fight or freeze response. It commonly manifests with physical symptoms, including feeling shaky, nauseous, having trouble breathing, or feeling as if you might pass out. In children, sleep disturbance is very common. Typically, children will have trouble falling asleep due to excessive worry thoughts, somatic symptoms, which are physical manifestations of emotional distress. And these are prominent in anxiety, such as headaches or belly pain. Excessive worry is the hallmark of anxiety. A red flag for anxiety is a child who has adult worries, such as worrying about health and safety of caregivers or family finances. For JM in particular, worry about physical symptoms, as you heard, related to illness or factors related to medical management can cause significant distress. Phobias, such as a fear of needles or medical procedures, can also be part of anxiety for these kids. We often think of anxiety as an internalizing disorder, meaning symptoms are focused inward, like excessive worry or negative self-talk. However, anxiety can also manifest as an externalizing disorder, such as acting out, tantruming, getting in trouble at school. These can also be signs of anxiety. Reassurance seeking is characterized by excessive questioning and needing to know everything in advance. For example, a child may ask repeatedly, where are we going, who's going to be there, what will we be doing? So this should raise your antenna for anxiety. And avoidance is a final common pathway and can be difficult to reverse. It's associated with the development of depressive symptoms. I'll talk more about avoidance in just a second. So how do we manage anxiety? For parents and caregivers, it's your job to shield your child from distress, right? So it can be very difficult to encourage your child to do something that causes them anxiety and fear. If your child is nervous, talking to doctors, try to avoid accommodating their anxiety by encouraging them to speak up, even though it's hard. And you can even use that language. Acknowledging the difficulty and encouraging them to do what is hard. Externalizing the anxiety helps because it separates the disorder from the child and empowers the child to fight back against their anxiety by doing the thing that makes them scared. Sometimes I'll have kids name their anxiety, such as their worry bully or their worry monster, and then have them engage in activities that fight back against the anxiety. Oftentimes a therapist's main role, and then for parents, encouraging curiosity, exploration, and engagement among your children helps prophylactically prevent against anxiety. So oftentimes a therapist's main role is supporting parents in helping children to tolerate and manage anxiety. So needle phobia is actually a really common condition among kids with JM and chronic illness in general. And there are specific protocols, exposure-related protocols to address needle phobia that are actually very effective. We also work with nursing to use various numbing creams and distraction techniques. Child Life in the hospital and in the clinic, Child Life can be a great resource. These are professionals who have experience in distracting kids during medical procedures. Sometimes in extreme needle phobia, calming medications are used right before the procedure if the child has tried to engage in therapy and it hasn't helped. But Crystal, specifically, I would recommend that a psychologist or behavioral health specialist be involved to really go through that needle phobia protocol to help desensitize your child from that fear. Thank you so much for that question. Okay. So as I mentioned, medications, if indicated, can be helpful in cases of extreme anxiety. And I think, Crystal, this goes on along with your question. So in terms of, I mentioned avoidance before, and the cure for anxiety is facing your fears. So in small measured doses at first and gradually getting up to that extreme what's most hard. So this diagram illustrates the wave of anxiety. So a typical response to an anxiety-provoking situation, such as a fear of heights or fear of needles, is to get out of the situation or get off the ladder if we're talking about fear of heights. So this escape avoidance is very rewarding from a behavioral perspective because the anxiety goes away immediately and you feel better. But when you're faced with a trigger again in the future, your anxiety will skyrocket, probably even higher than before. And sooner or later, you won't be able to cross the bridge or stand on the balcony to enjoy a sunset, for example. So in order to master your anxiety, individuals need to be exposed to their fears in a specific way so that we don't cause flooding, which is too much anxiety too soon. So the physiological arousal that's associated with that fight or flight response can't be sustained indefinitely, and it eventually goes away. And this is known as habituation. So in the case of needle phobia, usually a therapist will have the child kind of look at pictures of needles first to allow the child to gain a little bit of empowerment and feeling comfortable with that, and then kind of gradually work up to maybe holding a needle or putting a needle on their hand, not in their hand, or putting a needle in a doll. So kind of that gradual exposure. So just like jumping into a cold pool, the body eventually becomes accustomed to the water and you no longer feel cold. So the next time you're faced with a trigger, the anxiety peak won't be as high. And after multiple exposures, it goes away completely. So in the case of needle phobia, this is a protocolized approach and can be very helpful, starting really small at first. In terms, just a little bit about cognitive behavioral therapy, and I will acknowledge that there are many different types of therapy, such as play therapy and interpersonal therapy, but we're just going to talk about CBT today because it has the most evidence. So it's based on the principle that our thoughts affect our feelings and our behaviors, and that anxiety and depression distort our thoughts. So by challenging and changing maladaptive patterns of thinking, we can help fight depression and anxiety and feel better. What are the thinking patterns that I'm talking about? Here are some examples of them. So all or nothing thinking is thinking only of outcomes at the extremes and not seeing all the possible outcomes in between, like the gray zone. For example, I got 1 B, and so now I'm a total failure. This is an example of an all or nothing thinking thought that is a thinking trap that the therapist would work with the patient on adjusting so that they don't feel like a total failure. Catastrophizing is imagining the worst case scenario, like my boyfriend broke up with me, so no one will ever love me again. Mind reading is believing you know what others are thinking without evidence, such as, and this is more appropriate for your teenager, they didn't text me back because they don't like me. Overgeneralizing is making sweeping judgments based on 1 or 2 experiences, such as thinking no one at the school likes me when one friend is mad at you. Fortune telling, believing we can predict the future. No one's going to talk to me at this party, for example. And then an example of jumping to conclusions would be my parents had 1 fight and so now they're getting divorced. Also, there's focusing on the negative, which is common in depression and involves failing to see anything positive, like thinking about the 1 question you got wrong instead of all the ones that you got right. So the point is that we all have automatic negative thoughts that are sometimes unhelpful or inaccurate, and in CBT, the therapist helps the patient to recognize these thinking traps and then challenge them so that they feel better. I'm sorry, I'm going a little bit quickly, I'm realizing the time. Behavioral activation is a part of CBT that's really can be very helpful for depression. So it's based on this principle that a lot of people think that they have to feel better to be able to do the things that they enjoy, but actually it's the opposite. And you have to start doing the activities that you enjoy first, and then you'll begin to feel better in terms of your emotional health. So this is called behavioral activation, and the therapist will help the child or the parent set small action-based time-limited goals and pursue them, or plan pleasurable activities as one way to engage in behavioral activation and improve mood. These are some coping skills that also are done in therapy, such as mindfulness, deep breathing, muscle relaxation, guided imagery, and problem solving. And the deep breathing and the muscle relaxation can be helpful for extreme anxiety about procedures. I had a little mindfulness exercise I was going to walk you all through, but in the interest of time, we're going to skip that today. But I would encourage you to go to the website at the bottom, the NewYorkTimes.com guides, and they have a number of guided meditations for kids and adults as well. Here are some other of my favorite resources. The Worry Too Much book is for children, and it helps explain what anxiety is. Freeing Your Child from Anxiety is a great guide for parents on how to address kids and teenagers with anxiety. And then the Mindfulness Well Guides, as I mentioned, and then Headspace is an app that has meditations for toddlers, kids, teenagers, adults. Kind of it runs the gamut, and I recommend it to all of my patients. I don't get any money from them. Just a bit about medication. So selective serotonin reuptake inhibitors, or SSRIs, are known as antidepressants. They are also the medication that is used to treat anxiety. So it's the same medicine for both anxiety and depression. These medicines are usually very well tolerated with very few side effects, most commonly a headache or upset stomach for the first couple of days, and that tends to go away. And in the case of moderate to severe impairment in terms of anxiety and depression, and where therapy is not helping or the condition is getting worse, then we would recommend the use of medications. And in terms of the literature for severe anxiety and severe depression, we know that a combination of medicines and therapy is going to have the most robust response. It's hard to describe how people experience the effects of these medicines, but these are some quotes that I took from my patients who have let me know how it's affected them. So one patient said, "I didn't know I didn't have to feel this way all the time." Another one said, "It's like I was living in a cloud and now that's lifted." A parent has said she's more like herself about her teenage daughter, and "I don't get mad at every little thing anymore." So those are some examples. I started off by talking about the bidirectional relationship between physical and mental health. We spoke about depression and anxiety in children and teens and ways to help recognize and manage symptoms. It's also important to think about overall wellness and all of the factors that contribute to well-being, so especially sleep and nutrition, physical activity, and family well-being as a whole, especially siblings as well. And then in terms of family well-being, parent support is incredibly important. So it can feel selfish, hard, or even impossible to think about your own health and wellness as a parent or a caregiver of a child with a chronic condition. But I wanted to take a moment to highlight one of my favorite analogies on this slide. We know that parents of children with chronic conditions have higher rates of depression and anxiety. And so it's really important to attend to your own emotional needs the best you can in order to be able to care for others. There are several other issues. There was one question that I wanted to address really quickly. I know we're running out of time, but the question was about vulnerable child syndrome and how to prevent that. So in case you're not familiar, that's vulnerable child syndrome occurs in kids who have had experience with a life-threatening condition or who live with a chronic illness. And it's characterized by parent overprotection. And so I just wanted to say that the tendency for parents to overprotect children who have an illness is a very natural and expected reaction. And it's just important to be aware of your own responses to your child. And again, the recommendations are to address any parent's emotional health needs. And that doesn't mean that you have to have clinical levels of anxiety or depression, everybody needs some degree of support. So I would really encourage any parent of a child with a chronic condition to have a sufficient amount of support. And then treating your child as much like a typical child as is possible in the context of their condition, which includes setting appropriate limits and boundaries, and then allowing them to participate or engage in activities that they wish, unless explicitly recommended by your doctor. And if you do have questions about what they can or cannot do, kind of going to your doctor and getting their guidance on that would be my advice in the case of a vulnerable child. So thank you.